Following a little bit of a break, welcome back again to the Pager podcast. In this episode, it is my pleasure to speak with Dr. Kathryn Mannix. Having retired from a career in palliative medicine, Dr. Mannix is now a leading campaigner and communicator regarding the public understanding of dying. She's written 2 brilliant books, With the End in Mind and Listen, which I'd both highly recommend. True to one of Dr. Mannix's aims, we start off by talking a little bit about misconceptions surrounding dying, with a little bit of a historical perspective too. We discuss the ways in which, as a society, we could have better conversations about death, all the way from school to healthcare settings. The episode is interspersed with lots of stories and practical tips taken from a career in palliative medicine, and I hope that you enjoy it. As ever, we would love to hear what you think. Do get in touch with us, pagerpodcast@gmail.com by email. Do you have a topic that you would like us to cover? Any feedback? We would love to hear from you. Brilliant. So, Dr. Mannix, thank you so much for joining me today. It's so kind of you. I know after your week of holiday to be catching up with me on what seems like a bright Tuesday morning with both of us.
Yeah, thank you for inviting me. It's lovely to be here.
Over the last couple of months, I've been avidly reading your book, With the End in Mind. And one of the main kind of aims, it seems, that you have is opening up a public conversation around dying and perhaps talking about some of the misconceptions that people might have surrounding it. So I was wondering if we could just start off just by talking about what sort of misconceptions you think there are out there around dying, both in terms of the public and also perhaps with medical professionals as well.
Yeah, sure. So I think probably they are the same group of people, because we take medical professionals from our public that doesn't understand about dying. And we take them into university and we train them to be doctors and nurses and paramedics and allied health professionals and all the rest of it. And we train them to stop people from dying. So they still don't understand dying when they graduate. And then they become foundation doctors and newly qualified nurses. And there is somebody in the final stages of an illness in their care. And the job is not to stop them from dying. And my goodness, well, what is the job then? What do I do? My stethoscope's no use to me here. My encyclopedic knowledge of antibiotics is redundant. What am I here for? What is it mine to do? So let's think about the public understanding of dying and how it could be a different understanding that we bring with us into medical school that would make that situation as a newly qualified doctor or nurse feel completely different. So you probably know that my weapon of choice for my campaign is stories. So I'm going to start with a story, of course. I'm going to tell you about a lady called Annie. And Annie was born in 1900, and life expectancy for female infants in England and Wales in 1900 was 48 years of age. Fascinating. So on average, a female child born in 1900 would get to see the inauguration of the National Health Service in 1948. But half of them would be dead by then. And the other half would be, at the peak of their normal distribution and starting to die on the other side of it. So much for statistics. Now, Annie's interesting to me for 2 reasons. The most interesting thing about Annie to me is that she's my maternal grandmother. But the other thing that's really interesting to me is her life experience, because as a teenager in the 19-teens and as a woman in her 20s in the 1920s, because we always knew how old she was because she was the same age as the year, she had the same experience of dying and death that women, and it is principally women, had for the previous several hundred years, in that she was one of the older girls in a big sib ship. And so when people were sick and were looked after, they were looked after by the other women in their family. If they were so sick that they might die, they stayed at home and were looked after, because this was not a wealthy family. She was born into poverty at the wrong end of Liverpool. So in fact, if you wanted to recalculate her life expectancy, it probably was early 40s or even younger than that at birth. By the time she was in her mid-30s, which was in the mid-1930s, she had been married. She was a widow. Her husband had died of sepsis. He had appendicitis and his appendix ruptured. The oldest of the 5 children that she had died of diphtheria that we routinely immunise children against now. She was pregnant with her 5th child when her husband died. So far, so tragic, but also so familiar with the process of what happens while people are dying. She looked after her parents, she looked after siblings. And so we get into the war years, we get to 1948. She's reached her life expectancy at birth. She's still very much alive. She's got 4 surviving children, all quite young. When you look at what happened to life expectancies at birth in the second half of the 20th century, they'd already been rising because we got better sanitary infrastructure. We'd begun childhood immunizations, things like that. But the technical changes that came largely on the back of the war efforts, so that anesthesia was better, which meant that surgery could last for longer, which meant that deeper surgery could happen. Antibiotics were beginning to be invented. You know, we had better chemotherapies, radiotherapy was getting more focused and less toxic. So life expectancy started to rise further in the second half of the 20th century because medicine got clever. But the other thing that happened was that people who were so sick that they might die didn't stay at home to wait for it. They went to hospital, where the forces of modern medicine applied themselves to avoiding their death. And very often they were successful, which is why life expectancy is rising. So 2 cheers for that. But we've lost the 3rd cheer because now dying is a medical thing in a hospital rather than a social thing with your family around you at home. So when Annie was chatting to me when I was a newly appointed consultant in palliative medicine, which was in 1995, which, because you're a mathematician, you will know means that she was by then in her 96th year of life. So she's way outlived her life expectancy at birth. And the conversation she had with me was about her concerns about her dying. Not about what dying would be like, because she knew what dying would be like, because she'd seen it up close and personal so many times that she knew what to expect. And she knew that she would become more frail and more tired, and she was doing. And she knew that she would sleep more and be awake less, and she was doing. Her concern was that her children, my mother and her siblings, now in their 60s and 70s, wouldn't know what to expect, because she told me they'd never been with somebody who was dying. And that was a real light bulb moment for me. This is the generation that lost familiarity with the process of dying. And those people now are our most senior people. Almost none of the patients who we meet now are old enough to have been the generation that was familiar with dying. So how do people get familiar with something they don't know anything about? Well, they read it in the papers, they see it in the news, they see it represented in cinema, they see it in soap operas. So we don't know when we don't know something, because we fill the gap, we fill the vacuum with information we've gleaned from other places. So people glean information about dying and death from the same places that you might glean information about air travel if you'd never been on a plane. And if you only knew about air travel what you read in the media and see in Hollywood, you would never get on a plane because of all those unrestrained snakes, drunken pilots, airballs in the sky, etc., etc. So the difficulty is that people think that they know about dying and death, but they've got access to poor information. So the other thing that happens is, because I wrote a book about dying, I do book festivals. And the lovely thing about book festivals is that there's a table at the end where people can bring their books. They can buy books there, but they very often bring books, and they're really well thumbed. And that's lovely to see. And they ask you to sign your book. But as they do that, they tell their stories. And what happens every single time is that the queue takes forever, because everybody's telling me their personal death and dying story. So people are making friends in the queue. I don't know, babies might have been born in the wait for those queues. They take so long sometimes. But people come to the front and they tell me their story. And very often they do this really interesting thing where they kind of look around them to check whether anybody else is hearing. And then they say, when my mum, husband, child, friend died, this is going to sound a little bit weird, they say. But actually, do you know, it was really rather lovely. It was so gentle, and we were all there, and we watched them gradually losing consciousness. And then from time to time, we could see they were still smiling at us. And sometimes they said things and we didn't realize they were still awake. And gradually they became deeply unconscious, and their breathing changed, just like you said in your book. And when they stopped breathing, it was really gentle. There was no awfulness. It wasn't at all what we were expecting. It was really lovely, and I was so glad I could be there. And I think, yeah, okay, great. And then they say, but we never tell anybody about that, because we know that what we experienced was so unusual, that dying is usually so terrible, and we don't want other people to be upset by their experiences because our experience was so lovely. And I can feel my heart sinking. And I have to say to them, I'm delighted that what you saw is what you saw, what you experience is what you experience. And that's what it's usually like. The next time you're at a deathbed, it will probably be very similar to that. When it's your own deathbed, it will probably be very similar to that. Please tell people. Please go out and say, please challenge people on public transport and in your friendship groups, and when you're chatting on the way out of synagogue or church or whatever it is, because it's really important that your story about ordinary dying gets at least as much prominence as the really unusual stories about terrible dying. So in a nutshell, ordinary dying seems to be about running out of energy. And there's some really interesting research now coming out of the regional council in the Northwest, looking at metabolic changes towards the end of life. And what they think they're mapping is a mitochondrial failure, running out of ATP. So for the non-medics amongst us, what we're observing of people running out of energy at a whole body level seems to be what's happening at a cellular level in our bodies at the very end of life. And that rest and recuperation is more important than food. Often people lose their appetite towards the end of life, distresses their families, but actually it's okay. It's okay, your calorie intake isn't very high because you're not doing much to burn calories anyway. But sleep is the thing that recharges those energy batteries, gives people a chance to wake up and have another conversation for a while before they run out of energy again. And the very end of life is a sequence of events that is as predictable as the sequence of events during giving birth. It's just we haven't stood back enough to notice it. So as a junior doctor, I would always be at the pointy end of somebody dying. The job was to stop them from dying. So I'd be very worried about that person's oxygen and somebody else's potassium and somebody else's kidney function, somebody else's intracranial pressure. But behind that kind of battery of things that are happening to these individual patients, if you take one step back, you see the same thing happening to all of them, which is they're running out of energy, they're gradually becoming unconscious, that as they lapse into unconsciousness, the only bit of their brain that's still working is their respiratory center, driving their breathing in reflex cycles. And we call that Cheyne-Stokes respiration, or a variety of other names. But basically what we're seeing is cycles of deep to shallow and back again, fast to slow and back again, losing complete sensory input from the body. So that really tender part at the back of our throat that we would never allow anything to touch without swallowing, coughing, gagging, we don't feel it anymore. So saliva can pool, or the fluid that we're using to clean people's mouths can pool at the back of their throats. It doesn't stop them breathing. They breathe in and out through it. Gas going through a film of fluid bubbles, so it makes a bubbling noise. It's a clicking, peculiar sound. People call it the death rattle, and they're frightened about it. But actually what it's telling us is this person now has no sensory input from their throat. They are deeply, safely, undistressedly unconscious. And that's okay. They're dying safely. And at the very, very end of somebody's life, it's during one of those slow phases, usually in their breathing. And there's an out breath that just isn't followed by another breath in. It's not a special breath. It's not an EastEnders sit up and tell you where the treasure is buried breath. It's not choking or drowning. It's just very gentle. And in fact, all of us in palliative care have had the experience of walking into a room where a person has been dying for a little while. And we go in and the family are sitting around and they're chatting, and maybe somebody's stroking their hand or, rubbing cream into their leg or whatever. And we realise the person isn't breathing and the family hasn't noticed because it's been so gentle. They've been expecting something dramatic. So ordinary dying, less terrible than most people are expecting. And actually a process that if we can tell people what to expect, whether they're family and friends or whether they're doctors and nurses and other professionals, we can gauge how they're doing, where they are along that process, and be companions with them and explain to their family what's happening as it goes along, so they're not misinterpreting the noisy breathing as choking, drowning, trying to speak, being distressed. And at the end of that dying, a family goes into their bereavement aware that what they've seen has been safe and comfortable dying, which makes for a much more comfortable bereavement than being traumatized by misinterpreting what you've seen.
I think as you've gone along, you've answered quite a few kind of questions that I jotted down throughout this. And I suppose one thing I'd also like to add is that it's also something that's very important for the patient themselves to understand.
Yeah, you're right. And in a way, that's part of the problem of only starting to talk about it when a person has become a patient, isn't it? If this was widely publicly known, then each of us as people would have experience of people dying, during which we'd be recognizing the phases. Now, it might be that, you're on the emergency room tonight and a person comes in and they've got, end stage respiratory disease, and they're blue and their oxygen levels are dropping and they're barely rousable and they've got crackles and consolidation on one side of their chest, and you know that they've got a lower respiratory tract infection, they've got a pneumonia for the lay people who are joining us, and that we've got antibiotics that might very well make a difference to that pneumonia. But the thing that's really important at this point is this person's life is hanging in the balance. It's possible that with oxygen and antibiotics and fluids and chest physiotherapy, their life can be saved. But it's also possible that they might not be savable this time. And so they are currently sick enough to die. And the doctors and nurses looking after that person and the family around them need to acknowledge both of those possibilities. And that doesn't currently happen. What happens is the doctors say to the family, oh, this is a chest infection. We're going to give antibiotics. We're going to give fluids. The physio is going to come along. We're going to use a machine that builds up the pressure of the oxygen as they're breathing out and holds the tubes open and all these fancy gadgets. And when that person has died, their family will say, nobody told us that they might die. We weren't ready. But the doctors and nurses knew. So we need to think about recognizing the possibility that somebody's sick enough to die, talking the family through the possibility and offering to talk the patient through the possibility if they want to do that. And then if we save their life, everybody's a winner. That's okay. But if we don't save their life, families have had the opportunity to gather, to say their farewells, to make their peace in a way that takes them into a better bereavement. And of course, that's the very thing we were all robbed of during COVID, that's made the COVID bereavements during COVID, whether of COVID or not, so much more difficult. So we need to recognize the process. We need to be able to work out where the person is in the process, and we need to include it in our thinking, even when we're working to save the person's life. Because it's quite possible we might have that conversation with that family and they say, oh, hang on, Mum was very clear about this. She actually didn't want to come back to hospital again after the last time. Last time she said she was ready to die and she's finding her days are a burden. And she said she really wouldn't want antibiotics and oxygen next time. She wants to be peacefully allowed to die. Okay, so now we've got to make a decision in the person's best interests, because that's not a decision for the family to make unless that person's got legally standing lasting power of attorney. But now we know what she would want. We've got a choice about the way we take her care forward. We might give antibiotics or we might not. We might say, well, she's hot and feverish and that will be uncomfortable. We'll get her fever down with paracetamol but we won't try and fight the chest infection. She's breathless and she's struggling, so we will give her a little bit of oxygen because it would make her feel more comfortable, or we'll give her a drug that stops the brain from noticing that drive to breathe so hard and will help her to relax, even though her oxygen levels are lower than would be comfortable for most people. So we've got now a conversation we can have that's about, are we going to go all out for saving this life? Are we going to go all out for palliating this death? Or are we going to tread some kind of middle path, but all be clear that dying is possibly more likely than living under these circumstances? So we've got to be able to recognise it, and we've got to be able to talk about it.
And I think perhaps one of the misconceptions out there is that palliative care is an all or nothing route that people can go down, which encompasses withdrawal of everything else and only focus on the sorts of things that you've just mentioned, whereas actually some things can happen in simultaneously.
Absolutely right. And people who are in our specialist palliative care units, which are our hospices, there are bits of equipment that we don't have in hospices. So we usually don't have a cardiopulmonary resuscitation trolley. Okay, people know if they come into a hospice that actually, if we're going to do CPR, it will be as a first aid procedure to get them back to hospital, if that's what they would want, recognizing that if you do have a cardiac arrest because your heart has stopped first, but everything else is working okay, then CPR is first aid that might get you to a place where you can have the treatment that gets your heart going and everything else is being kept okay enough for you to survive. Although usually that doesn't happen. Public don't know that, do they? They don't understand how low the survival statistics are for CPR. But at the same time, in our hospices, we're dealing with a lot of people where their heart is going to stop, but isn't going to stop first. It's going to stop last. At the end of that phase of dying, after respiration has stopped, a couple of minutes later, when there's no more oxygen circulating, the heart will finally, usually fibrillate and then stop. And that's not a cardiac arrest. We're not going to do CPR. We're not going to transport them up to the hospital and ask for an intensive care bed. We're going to hold their hand. We're going to play their favourite music. They're going to have their most beloved people in the world around them. And that's what we are going to facilitate. But most people who are in a hospice are there not because they're dying, but because they've got complicated symptoms and we need specialist support around them. So they may very well be having blood transfusions and intravenous antibiotics and very specialist nerve blocks delivered through needles by people who are highly specialised in those things. They might be having psychotherapy for really complicated family dynamics or depression or anxiety. It's not just a place where you go, get put in a beautiful bed in a beautiful room and beautiful people serve you beautiful meals, singing beautiful songs while you just die. It's technically very, very active care to restore people to the best possible living they can still have, despite the fact that there's an incurable illness progressing in the background. So palliative care is about making things better. It just isn't about prioritising saving a life over everything else.
And I have to say that I was surprised by the statistic that you gave in your book, that over half of people who go into hospices actually end up leaving again to either have care elsewhere or to go home. Because I think this almost went at odds with what my impression of a kind of a hospice was, in terms of it being more of a terminal, which probably isn't the best word to use, but with more of a kind of an endpoint in a journey rather than a place that's offering a particular service, as you mentioned, for symptom management and trying to get people in the best possible position.
So it very often encourages people, I used to run an outpatient clinic in a hospice and people would be quite surprised. They got the letter and it had the hospice letterhead on it, but it's an outpatient clinic. We didn't think you had people well enough to come to outpatients, and I would very often give them a guided tour of the building and say, this pain or this breathlessness or this itch or this anxiety that we're talking about today, we can probably sort it out with you just living at home. But if we needed you to have a few days of being just surrounded by really specialist nurses and physios and all the rest of it, then this is the place that you would come. But I couldn't offer you a bed today because we're waiting for 3 people to go home and their beds aren't ready yet. And hang on, you're waiting for people to go home? That's not what I was expecting. I thought everybody went out in a box. So yes, it's really important, isn't it? Not just that we understand the process of dying, but we understand the purpose of palliative care as well.
I suppose, do you think that there's a time that's too early to be discussing the possibility of death and what people's wishes might be surrounding it?
No, I don't. I think we should be talking about it at school. I think it should be as part of the national curriculum. We've got all of this stuff about life cycle in the national curriculum, which is about relationships and about puberty and biology and sex and reproduction. But that's not a whole life cycle. And the other end of the life cycle is just not dealt with. So teachers aren't taught how to deal with grief and bereavement. On average, 1 in 30 school-aged children is carrying a significant personal bereavement, sibling, parent, a parenting grandparent, or other really significant person in their life. So, 1 in 30 is 1 on average in every single classroom. So we're ducking our responsibility as an educational workforce by not preparing teachers to be able to work with a class when a student in the class is dying and has died, or to work with a class to bring a student back into the class after their parent or their sibling has died, and to normalise the process of ordinary dying. Some schools keep pets, and I remember talking at University of Derby a few years ago about how important I think it could be for children to observe the guinea pigs have a great short enough life cycle to fit into a primary school career, where the baby guinea pigs grow up and become mummy and daddy guinea pigs, and then become very old guinea pigs, and then become dying guinea pigs, and then they die. And what are we going to do with the dead guinea pig? And let's think about how that's going to return to nature, and where shall we bury it, and how shall we remember it? And let's be sad because we loved that guinea pig and we've known it since it was a baby. So that's a whole life cycle. And at the end of my talk, a palliative care nurse specialist said to me, I need to take you up about the guinea pigs because my husband is a vet, and he tells me that school guinea pigs have the most extraordinary life expectancies. Because when the guinea pig looks sick enough to die, it gets sent to a particular family to be looked after. And once it's better, although often looking surprisingly different now it's better, it comes back to school. So school guinea pigs never die. And that's part of our problem. So yes, we need to get dying, death, grief, supporting each other, being curious about these things, being kind, understanding that grieving makes people sometimes want to be quiet, but sometimes want to just be normal. They don't want to talk about death all of the time. That needs to be part of our school curricula so that adults have similar frameworks for understanding it. And that gives us the platform for talking to grown-ups about dying, death and grief.
Mm. And what have you learned over your career about the best ways to support people who are grieving? Because it seems to me that I suspect as somebody who might come in and really want to help, particularly if they're early on in their career, the tendency might be to get too involved and to ask too much and try to do too many things too quickly. And I'm just wondering what sort of patterns emerge as to what really helps people in this process.
Oh, that's a really insightful question. When I wrote With the End in Mind, I thought that was it, that, I was retiring, I was going to try and do something about public understanding of dying, and then that was it. I was going to be off into a happy retirement. And so far that has not happened because the response to the book was extraordinary. And part of that was about people getting a better understanding of the dying process. But another part of it was people making contact to say, okay, you convinced me we need to talk about this, but I don't know where to start. I've got this grieving friend. I don't know what to do. My parents are getting really old. I don't know what to ask them. I'm in my 80s. My adult children won't engage with me to talk about this stuff. All sorts of things that are about the conversations that we know that we need to have, but we're just not quite sure how to get there. And it turns out that when you write a book that becomes a bestseller, which hadn't been the plan, but that is what happened, your publishers then want another book, of course. And I kept saying to them, no, there isn't another book. I've said what I came to say. I'm done now. But once I started to get all of these letters, and thousands of them, I started to think, actually, probably I have got something to say about the way we talk about this. And the thread of the messages was, I don't know what to say. I'm sure if I knew the right words to say, I could make things better. If I could just give people a really good talking to, then the whole thing would feel different. And what I know from being in those rooms, having those conversations so often, and what I know from my practice of being a cognitive behavior therapist, of being a psychotherapist, is that almost all of really, really good communication isn't about what we say, it's about the way we listen. So I went back to my publishers and said, I think there might be another book. And they said, yay, great, but it hasn't got to be about dying. So I did write about listening. And so that's this. And calling the book Listen, I think, says it all. You perhaps don't need to read the whole book, you just read the front page, and it says, listen, how to find the words for tender conversations. So 2 things there. One is that the key is listening. And the other thing is that if we call the conversation difficult or challenging or courageous because we feel daunted by it, it will make us go into it kind of with our armor on, defensive and ready to do this hard thing. Whereas, in fact, the reason we feel daunted by it is we recognize that there is a tenderness in the situation. Maybe we feel a bit emotional about it. We know the other person probably feels really emotional about it. And we're trying to somehow skip over the emotions and just get into words, when really this is about us meeting at an emotional level. So if we call them tender conversations, we're taking our armor off. We're meeting not as a person who's doing something to you and a person who's having something done to you. We're meeting as people. So bereaved people want to be treated like people. They want us not to ignore them. They want us not to look embarrassed and turn down a different aisle in the supermarket or cross the road when we see them coming towards us. And bereaved people describe all of these things. They haven't forgotten that they're bereaved. So if you say the dead person's name, that isn't going to suddenly remind them, oh my God, she's dead and I'd forgotten. It's going to say that you remember too. I've been thinking about you and I've been thinking about X and I wondered how you've been doing. And that grief is a process that's healing for us. It helps to process and get to a place where we can live alongside the loss. It's never going to get better. Life is always going to be different. So we just trust the process. So none of us is going to be able to come along and do something that makes the person magically better. All we can do is be their companion for the duration of a conversation, or send the occasional text message to say that we're thinking about you, or I'm remembering that time when, and the name of the dead person, and I were doing this, and how funny it was, or how kind they were, or how fond of me they were, or how much they really enjoy football or fishing or a visit to the art gallery or whatever it is. And you're just giving them little snapshots of their person and making them understand that they're not the only person who's remembering. They're not the only person who's missing this person. So we're not going to make grieving better. Grieving is the process that makes us able to bear life without the person we're bereaved of. And all we can do is be companions. So sometimes it's about going along and saying, okay, I'm free for an hour. What would help you the most? And sometimes that's doing their washing up and their vacuum cleaning. Sometimes it's just sitting and chatting about anything and everything except their bereavement. And sometimes it's a conversation about the person who died with tears and laughter and emotion. But they get to choose. We don't dictate it.
And I think that perhaps comes back to maybe a tendency that I feel, I think I alluded to it before, but to perhaps want an easy, quick solution, which there isn't necessarily in this scenario. And it maybe also links back to, I think, our early discussion. Perhaps the treatment sometimes of people in grief is almost mirrors our treatment of death in general, in that if we treat death as something that shouldn't happen and something that is hidden, then we're almost liable to treating grieving in a similar sort of way and trying to avoid people trying not to talk about people who have died. I don't know if you think that's an accurate...
I think it is. And grieving people describe exactly that. They describe friends falling away. They describe support from people from unexpected quarters, people who are themselves bereaved, usually step up. So they recognise what it feels like, and they've already had the experience of the usual friends falling away because they feel so helpless. And so often people who are grieving find a whole new set of companions and helpers and supporters who may become lifelong friends, or may just be people who walk with them for that part of their journey and then retire back again. So yes, grieving people often say they feel as though they're invisible. And it's because we look away from them because we're looking away from their grief. So just having the courage to say, I heard that X died and I'm so, so sorry. That's just an amazing start. And then the thing about grieving is that it's exhausting. It takes up a lot of emotional energy. And so quite often the thing that we could do that would be helpful is practical things. There's a whole lot of admin to do when somebody's died, if you're managing the estate. People call it sadmin, which I think is rather good. But if you're good with IT and computers, and there's an older person who's trying to sort out their spouse's estate who's not great with computers, you know, can you go along and sit for half an hour and just get onto some of the websites that they need to do? Can you help with the phone calls to tell insurance companies and banks? Can you take them along to the registrar so they can get the death registered without worrying about driving safely because they're so distracted by their bereavement that they're not focusing on the road very well? So there are all sorts of practical things that we can do that aren't making the bereavement any better, but they're enabling people to get through the process of stuff that needs to be done. I've got friends who talk about people leaving them meals on the doorstep, or just popping around and saying, I'm not coming in to stay, but you know, we had pasta for dinner last night and there were 2 portions left over, so they've frozen them separately. You can stick them in your freezer, and sometime when you can't think what to cook, they might be useful. So take a pie. Maybe that's the maxim.
I wonder if some people worry that because everybody is individual in themselves, then that therefore gives you nowhere to start with how you approach this process. But I think you've given some quite kind of clear and I think overall simple things that people can do that I think work or tend to work across the board with regards to listening and helping with these sorts of things. I think that's very useful. I wanted to go back a little bit and perhaps tie this in with the dying process itself, and just ask, what impact does the preparation for somebody's death, and again the care for somebody who is dying, have on the bereavement process for those who witness it later on?
Oh, that's a really good question, and there probably will be studies and data. And because I'm not really a bereavement expert, I don't know the studies and the data. But the things I've just observed from practice over the years is that families knowing what to expect, whether or not their dying person wanted to be part of knowing that, although usually they do, which is really interesting. Families knowing what to expect are much more able to be present along those last weeks and days and hours of the person's life without panicking, without suddenly dialing 999 and the person getting blue lighted off to hospital if they've been at home, or being able to visit at the hospital and understand what it is that's going on. And the way we make sense of everything is through stories. So one of the things that you notice around a deathbed is the family doing almost like handovers. So lots of families draw up rotas of who's going to be sitting with the dying person, and the new shift comes in. And the previous shift will say, oh, so he hasn't been awake now since about 7 o'clock this morning. But at 6:30, he sat up, he wanted a cup of coffee. He only managed 3 sips, but he said it was delicious. And then he went back to sleep again. So that shift goes off, the new shift comes on. And this person, it turns out, is never going to regain consciousness. But when they hand over to the next shift, what they say is, he hasn't been awake while we've been here. But at 6:30 this morning, he had a cup of coffee. He always loved his coffee, didn't he? Well, he didn't have very much. They said he only had 3 sips, but he said how delicious it was. And now what we're starting is the narrative of, he's been mainly asleep all today, but the last thing that he drank was, the last thing that he said was, the last person he had a conversation with was, and this is what they talked about. And those reminiscences will be retold at the funeral, and they'll be retold in the weeks and months that follow. So knowing what to expect, noticing the process of the dying, treasuring the moments that happen along the way, and being part of the end-of-life vigil and noticing what's happening during that really helps families to have a story that's almost like a guide rope that they hang on to through bereavement as they tell the story of the person's living and the person's dying, and the comfort they've taken out of observing the dying being what it was expected to be: gradual, gentle, comfortable.
And I think you write a few times about quite simple prompts or just questions from healthcare staff, such as, have you noticed that, I don't know, your loved one has had less energy over the last few weeks or something? And I think that's probably quite a useful thing for just actually making people almost realise or understand what they have really been seeing. The information is there, but actually being able to process it in terms of this narrative of the dying process is, I imagine, quite useful. And also being able to discuss it with other people as well. They can say, oh no, you're not wrong about this. Another family member can say, oh, actually, I've seen this too. I'm sharing in this experience together.
Yeah, absolutely. So there's something about creating a community around that person and helping them see themselves as a community. And the thing that you're alluding to that's a really, really useful skill in medicine is guided discovery. It's Socratic questioning. It's asking a question to which you know the other person knows the answer or can work out the answer. So I might say, what have you noticed about their energy levels over the last few weeks? And how does that compare to maybe 6 months ago or maybe a year ago? And as the family or the patient himself or herself thinks about that, they give an answer that describes, and they hear themselves describing, that there's more weariness and less energy now than there was 3 months ago. And it was even different 6 months ago and a year ago. So then you can ask questions that are much more synthesizing questions that ask the person to pull that together. So now you've described what's happening to your energy levels to me. What do you make of that yourself? So they now pull it together. Say, oh yeah, I am getting more tired over time, aren't I? Do you think it's going to carry on like this? So that's a very different way of giving them the information than saying, I expect what's probably happening is that you're getting more tired as time goes by. And they'll say, no, I'm just as alert. Well, because of course, when they're awake, they're just as alert as usual. It's just that the period of being awake is different. So by asking Socratic questions, by using this process of guided discovery, where they notice the difference and report it to us, They're not telling us anything that we're not expecting. But if they do tell us something that we're not expecting, okay, now we need to think about what's that exception about. So since I started taking those oxycodone tablets, all of that difficult pain that I was having has gone away, except when I try and stand up and twist myself around to sit down in the chair next to the bed, I always get a really bad pain in my right thigh when I do that. Okay, that's telling me something. It's telling me both that the oxycodone for whatever the other pain was is working, and that there's an incident pain here that sounds like I need to think about what's happening in that femur, because that's a different pain. It's being caused by a different thing under different circumstances, and we'll need a different approach to manage it. So we're asking people to report to us so that they notice. They say, I'm more comfortable, and their family hear them saying they are more comfortable, and that becomes part of the narrative for them all. Dad's pain was so much better once he started that oxy-what's-it treatment. But he did still have that pain in his leg, didn't he? And in the end, you remember, we had to ask the orthopedic surgeons about that pain, and they bashed a nail in, and then that pain just completely went away. And Mum didn't want him to have the operation. She thought he wasn't strong enough. But actually, he was so glad he did, because for the last 3 months of his life, he didn't have that pain in his leg anymore. So they're building a narrative, and we're responding to the stories that they're telling us by asking more questions.
And I think we've built a picture of what is quite a positive, if not kind of sad narrative. I wonder how commonly it is that actually this is flipped on its head, where actually there are feelings of guilt or regret around the circumstances of an individual's death, or the processes that have led up to it, or even in situations where perhaps mistakes have been made in people's care, and how we can still frame death in a way that is helpful and healthy going forwards, despite some of these kind of lingering concerns.
So a couple of things there. So I guess the first thing is that not every family is unified in their approach to the best way to look after a person, or acceptance that the illness is progressing and the progression can't be halted. So you will get family members who come and send emails or catch you in the corridor and ask whether there isn't something else that can be done. Is there another treatment? Would the intensive care unit help? Those sorts of things. So helping families to be on the same page as each other is a really important part of caring for a person at the end of their life. If there's dissent and dissatisfaction within a family, that can make the whole thing more uncomfortable for the dying person. And of course, if the dissent and dissatisfaction is because somebody either in our service or in our hospital organisation made a decision that the family disputes, and now we're further down the line, they are accusatory about that having been poor practice. Or even we dropped a bat, we missed something on a scan, something happened during surgery that was an adverse incident. Those things happen. So our duty of candour really matters at this point, because if at the time that something's gone wrong, we've gone in and really expressed honest truth and regret, then people are going to be disappointed, they're going to be angry, they're going to have the right reaction, and anger is part of the right reaction to something that should not have happening. But at the other end of that, you're much more likely to have preserved a relationship of trust with the patient and the family because of the candour and the regret. So it may be now you're still in the care of the same group of people, same oncologist, the same respiratory team, the same liver team who'd promised you the earth and you were going to have this, that and the other, and we'll get you a transplant. And now it's clear that you're never going to get to transplant because you're just not going to be well enough for the anaesthetic, even if an organ becomes available. So we're dealing with the disappointment, we're sharing the disappointment. But the truth is we are now dealing with the end of your life. And we want that to be the most comfortable, the most graceful, the most satisfying for you that it can be. How do we need to be? What do we need to do so that that's what we're offering to you? And the more we shy away from the difficult bits, the less we're able to be really present alongside the person.
Can we put a value on a good death, and therefore can we compare it to other things within a system that we might otherwise consider putting resources towards?
Great question. And I know you'll be aware that the Lancet Commission on the Value of Death has recently reported, and their document makes really, really fascinating reading. And they've looked across high, middle and low income countries. And obviously the value of death is very different in those different health economies. One of the things that's really interesting is how we are having a conversation about something that's a lost wisdom in high income countries, which is still relevant everyday family wisdom in most low income countries. So they understand dying, they understand the process. It isn't hospitalized, it isn't medicalized, it's social, it's important, it's respected. What they haven't got is access to the drugs that allow the symptoms of whatever the illness is to be well managed. Because just to be clear, dying only causes two symptoms. It causes loss of energy and it causes unconsciousness. Every other symptom that a dying person has are of the illness that's causing the death. So we just need to take a moment to hang on to that as a concept. And the war against opioid addiction that is being waged by the United States principally, but not only, is causing such draconian laws about the management of opiates in low-income countries that they are not accessible and available for people to have good pain control or control of breathlessness at the very end of their lives. So the value of death is different depending on what kind of economy you're in. But what we know is that in the high-income economies, the more industrialized the dying process is, and the American model of death on ICU is the most industrialized model, if you like, the principal costs associated with healthcare across a person's whole lifetime are accrued in the last 6 months of their lives. And almost certainly most of that is probably about futile interventions to extend a life rather than useful interventions to maintain the quality of the life. We know that early introduction of palliative care reduces overall costs, largely because it helps people to have symptom management without pursuing aggressive treatments, and it's the aggressive treatments that are expensive. So early palliative care reduces the costs in the health economy, but actually increases the quality of life of the people who are using it. And several of the studies about early introduction of palliative care also show that not only do people have better quality of life and opt out of invasive treatments earlier so they cost less, really counterintuitively, they live longer too. Because a lot of treatments are themselves so toxic and so enervating that the energy supplies that could be about good quality of living are taken up by just dealing with the toxicities of treatments.
I think that's really, really interesting. And it speaks to me perhaps that if we take all of our medical decisions as things that are made in individual moments, it's quite easy to see how care can be escalated again and again without a view of this process and what the actual aims are overall. It's much easier to do something in most circumstances than to perhaps not do something.
Yeah, and I think at each escalation, there's a question that needs to be asked. And the question is the aim of treatment here to give this person, or to give you, the person I'm looking after, the longest possible life expectancy or the best possible quality of living while you are still alive? And that's not a once and for all decision. So I've met people who've changed their minds about that several times. Oh, I'm only interested in quality of life now, doc. And then the next time I see them, the daughter in Australia is going to get married. So they want to survive now to the wedding. So I'll have treatment. Doesn't matter how toxic the treatment is, I'll have it because I want to get to the wedding. They get to the wedding, they go back to, I'm content now just to focus on quality of life. And now the daughter's pregnant, they want to see the baby. Now, that's another conversation about life expectancy and what's really important about celebrating this baby, this pregnancy for you. Because if I can't give treatments that would extend your life until the baby is born, what would you want to do now that helps your daughter to celebrate your love when the baby is born? So let's not just say, oh, we can do it or we can't do it. Let's say, what does it mean, whether we can do it or not? And that's really what the Lancet Commission on the Value of Death comes down to, is actually about the value of life at the end of life and what is really important. And that's why Atul Gawande's book, Being Mortal, is so important, because his title again says it in spades, because his subtitle includes the phrase, what matters in the end. And that's what all of this is about.
No, definitely. Do we check in with people often enough to see whether their aims or their priorities have updated? Because I suppose one of the dangers in talking about perhaps dying too early on, if it's not done properly, is that views are carried forwards from people who are in drastically different positions, perhaps a long time before, to the ones that they are in now.
Yeah, I think that's really important. And I think that it isn't that we talk about it too soon, it's that we don't talk about it sufficiently often. So there need to be triggers to revising those conversations. And maybe those conversations should be conversations that we have with our friends and our families frequently, even when we're well. So when you reach a particular birthday and you live in the UK, you'll be invited for cervical cancer screening if you have a cervix. You'll be invited for breast cancer screening if you're a person with breasts. Universally, on your 60th birthday, you get sent a bowel cancer test kit, and thereafter, every several years, another birthday bowel cancer test kit. Maybe it's time we introduced conversations about advanced care planning kit for people's 50th birthday. Congratulations, you're halfway to 100. We hope you get there. Whether you get there or not, this is going to be a useful booklet. Please have a think about some of the ideas and chat about it with your family. And then let's do that every 5 years. Let's send the kit out again. And so then, when we're meeting somebody in our clinic, in our cancer clinic, in our palliative care clinic, in our kidney failure clinic, in our neurology clinic, we say, please bring the most recent version of your 5-yearly checklist with you so we can talk about it and your values. And now we're going to drill down into a much deeper and richer conversation, because we're not starting from nothing. We're starting from a baseline where people have already been thinking about it.
Exactly. And I think that asking people to make decisions like this under quite pressurized situations, perhaps where, stories of people actually who are perhaps breathless and not really in a position to properly think about these decisions, having actually had that forethought and perhaps the chance to talk to family members about it is, I think, very important. But also and I know you've, I think, touched upon it in an example in your book, it helps people to bring up this conversation naturally without it being rebuffed in a way that people might say, oh, don't be silly, this is a too negative a conversation to talk about it at your sort of age.
Yeah, one of the stories that I love, and with the end in mind, is the story of Dan. He's the only person who's got his real name. in the book. And he read his story and, in fact, corrected a couple of sentences for me before it went to print, who was a young man with Duchenne muscular dystrophy, facing the very end of his life, and helping me to launch the advanced care planning materials for our region in the northeast of England. And what Dan saw was that filling in these documents about what treatments he would consent to and what treatments he would decline under any circumstances gave him a sense of control about his destiny, and that was really, really important to him. So I think if we approach advanced care planning from a sense of respecting people's right to refuse treatments they don't want, that's very different from advanced care planning as trying to talk about dying. It's not about trying to talk about dying. It's trying to talk about where you draw the line for interventions that other people might be very, very enthusiastic about on your behalf. And again, we talked before about families having different views. The view that counts, of course, is the person's view, and them having written it down is incredibly powerful. But it does need to be reviewed and revised. Dan did devise a very, very complex emergency healthcare plan, because it's no good just having a whole list of things we're not going to do. You know, a DNA CPR certificate, so we won't start cardiopulmonary resuscitation, but he isn't having a cardiac arrest. He's just in this difficult situation of having an overwhelming chest infection. We're the ambulance crew. We've pitched up at the house. Thanks for telling us not to start CPR, but we weren't going to start CPR. You haven't told us what to do. So an emergency healthcare plan, a list of things to do, is really important as well. And that emergency healthcare plan eventually came good for Dan, because he eventually, after the book was written and published, did end up in an intensive care unit testing his plan to its very limits, and it held him and it kept him safe and it got him home to die. So it did everything that he had hoped it could do for him. So we're never too young to talk about these things. There need to be punctuation points that maybe could be every 5 years from our 50th birthday, but also every time we have a significant health status change, and every time we have a significant life status change, when we marry, when we take on a mortgage, when we have a child, when we retire. All of those times are times to think about what matters most to us.
Dan's story also is an example of somebody who has changed their perspective on what gives their life value over the course, I think, of their illness. Because I think you write about him feeling very despondent at the beginning, and actually this his kind of spearheading this campaign being something that was incredibly kind of inspiring and motivating for him as well. I wonder, and I know we've been talking for a while. This was something that I was perhaps particularly mulling over the last week, but the idea that people often want to hide their suffering and hide their feelings from those who they love towards the end of their life or throughout their own illness, with a view of protecting them from that. And I wonder what your views are on this.
I've seen it so many times. I've seen sick people not wanting their loved ones to worry, so they don't talk about their own worries to them. I've seen families think that the sick person doesn't know how sick they are, and the family are keeping the secret to protect them. Almost always, when there's a secret, everybody knows it, but nobody realizes that everybody knows it. So everybody's lonely. And all of the people who would normally look after you in your distress can't look after you in your distress, because you've decided that you're not going to talk to them about this distress. So I think secrecy is poisonous, and the more we can be honest with each other, even though what we're trying to do, it's all born out of kindness. It's all love in the end. It's just love that is helping in an unhelpful way, and helping people to be able to talk about the thing that worries them most, even if it means that they're weeping together and talking about how difficult everything is together. They won't only talk about that. They will stop crying. They will regroup. They will laugh again. They will have good times again. But keeping the secret is a huge burden for people. That's not quite the same, though, as when somebody's using denial as their coping mechanism. Denial isn't secrecy. Denial is deciding at a deep psychological level not to accept an unpalatable truth. And I've written a little bit more about that in the second book, in Listen, but there is a story in With the End in Mind about a young woman who I looked after in the cancer centre and then looked after while she was dying, who never acknowledged the full extent of her illness. She would tell people that she had cancer. She would tell people that the cancer had come back, but the complications from which she was dying, she continued to talk about as reversible complications. And she was still talking about, I'm going to beat this thing, 20 minutes before she lapsed into unconsciousness and finally died. And we needed then to help her family to understand that it was too late in her dying trajectory for her to have the space to do the emotional work of accepting the truth. So her husband was really helpful in this regard because he was a mountaineer, and he talked about when you're climbing very, very challenging climbs, if you stop and think about the truth that you are alone on a windy, rocky pinnacle with thousands of feet below you, and if you slip, you will die, that's just not the most helpful thought to entertain at that point. What you're doing is thinking about, where are my feet? What's the wind direction? Where are my hands? What's my next move? Which muscles do I need to hold? Which muscles do I need to move? And that in some way denying the reality of the drop allows you to focus on the here and now. And that's exactly what his wife was doing. So the family was able to sit in her room and reminisce about her life and talk about all the things that they loved about her in the way that families around deathbeds do. They just couldn't use those conversations to say goodbye because she wasn't ready to have that conversation.
And I think in some ways, what people who are experienced in this field, such as yourself, or even from a kind of a mountaineering background, that there's a huge, I think, benefit from just the reassurance that no, you haven't done something wrong. You shouldn't have handled things in a different way. Because I imagine what could be alarming for a family in this scenario is wondering, gosh, have we got this entirely wrong? Should we have shattered this denial earlier on? Should we have done something differently? And that would have completely changed things and made things a lot better. Or actually, was this, from perhaps the only example of it they've seen, the right way to go forwards?
I mean, complete denial is very, very unusual, but she was a fantastic example of it. And usually denial starts to break down because the illness itself manifests so strongly that the person can't keep it up any longer. But what you do meet a lot of people doing is walking two roads. So most of the time they're on their, things are okay, it's going to be all right, they're going to find a cure, somehow, somewhere, this is going to be okay. And then some of the time they're on the other road of, well, but what if it isn't? And sometimes you can have conversations with people about two roads and saying, do you feel you could spend 10 minutes with me now on the road of what if, just in case your best hopes don't materialize? Are there any things that you would wish you had done or said or thought about at the very end of your life if we can't pull off all of your hopes and expectations? And it's a little bit like everybody writes a will, and we encourage people to write them when they're young and healthy, not when they're thinking about facing the very end of their lives. Is there a kind of will for things that are important to you that we just need to think about for 10 minutes, and then we're going to lock it in a vault and go back onto the road of, I want to believe things are going to be okay.
And I suppose my linked thought on this was that perhaps one example where there is particularly secrecy surrounds communicating to children around the extent of illness and the reality of dying, particularly with regards to kind of relatives and parents. And there's this desire, I think, which comes from a good place, to want to shield children from that reality. But I wonder whether it can lead to, as we've talked about, a rather abrupt kind of pattern of realization amongst children that can be harmful in the long term, whereas actually it might have been better to discuss things earlier on.
Yeah, it's again, very, very important concept. And there's another Lancet Commission looking at communicating with children about dying, both about communicating with children about other people dying, but also communicating with terminally ill children about the facts of their own mortality and their own dying. A lot of that work's being led by University of Oxford's Department of Child and Adolescent Psychiatry, and there's some fascinating work out there. But certainly the advice of their research lead, Alan Stein, who's professor of that department, is that children have fantastic imaginations and huge radar. And when their significant grown-ups are upset and distressed and keeping secrets, they know. And because their imaginations are so fantastic, what they imagine is usually 1,000,000 times worse than what we would tell them. If you're not allowed to go into granddad's bedroom anymore, but you can hear the bizarre noise that's coming through the door when he's breathing, then something's happened to grandpa. Has he been captured by aliens? Has he been turned into a dragon? Is he being tortured? What's going? Just grandpa is unconscious and going to die soon and making funny breathing noises is not going to be the thing that comes to their mind. So actually, come on in and see grandpa. He's very weak now. He's very nearly at the end of his life. It's okay. So you can sit on the bed by him. You can give him a cuddle. You can give him that drawing that you made for him. You can tell him all about it. He'll be able to hear your voice. He's listening with his eyes closed. Yeah, that's absolutely fine. Yeah, 5 minutes, is that enough? It's a bit boring, isn't he, grandpa, like this? Yeah, I agree. Should we go downstairs now and have a biscuit? Let's just make it be part of what's happening.
And I don't know if you listened to Sir David Spiegelhalter's Desert Island Discs, but he talks about actually the death of his son at quite a young age, and how, as a family and a community, they approached that, I think, in a very candid way. And I'd encourage everybody to find that.
To listen to. It's really, really powerful, isn't it? Absolutely fantastic.
Now, I know that I've taken up a huge amount of your time already, and that you're very busy catching up with things following your break from screens and Zoom. But I just wanted to say thank you very much for speaking with me. It's been a really illuminating conversation for me, and certainly given me a lot to think about going forward. So thank you.
Well, thank you for inviting me. It's been an absolute pleasure to talk to you. Thanks.
Thanks for listening to the Pager podcast. As ever, we'd love to hear what you think. Do get in touch with us via email at pagerpodcast@gmail.com or via Instagram, Twitter or Facebook. We'd love to hear what you think, and don't forget to share us with a friend. Bye for now.